epithelium, di ba? Columnar epithelium. But then it should be abruptly changing into this kind of, not that, but yung isang type of epithelium ito. That should be your stratified squamous epithelium. But somewhere in between them has this kind of epithelium. It looks transitional, but actually it's not. It's actually a dysplastic squamous epithelium. You say dysplastic, you are going to have changes like hyperchromatism, increased nuclear cytoplasmic ratio, increased cytoplasmic density, and then some have prominent nucleoli. Actually, this entire surface, this entire layer, you can note that the changes has occurred in there. Okay, so full thickness. If the change occurred in the first, if you divide this into three, 1, 2, 3, if the change occurred in the first 3 layer, first basal layer, then that's what you call your one. Special lang yung kuan.
So ano mo dito kung daan
okay.
Focus mo lang.
Nice. Isaksak na na muna diya, okay ra?
Oh, dapat dito.
Kani ba? Kani ba?
Okay lang.
Okay ra? Binamog ni buto na ba? Okay ra?
Okay ra.
So, ayos. Nice. Thank you, sir. So, kani siya, so apparently kani siya nag-change all throughout. In fact, if you look closely, yan, you see the changes very clearly. No? So, almost naked nuclei na siya, kasi increase on nuclear cytoplasmic ratio. So if this occurred here, then that's what we call mild dysplasia, or the CIN1 category. Now if it occurs 2/3 of the way, it's moderate dysplasia. They say it's CIN2. What is CIN? Cervical intraepithelial neoplasia. No? And then if it occurs all throughout, then that's what we call CIN3, or severe dysplasia. Others would even call this as carcinoma in situ. Okay? Carcinoma that has occurred within its limits. The limit is the basement membrane right there. There is no invasion. Still is confined within the epithelial layer. This is already cancer, but it has not yet spread. Okay? Carcinoma in situ. Alright? So you will see that there. And this commonly occurs in the SCJ, or squamo-columnar junction in your cervix. And that SCJ can most likely be found in the transitional zone, or your TZ. You know where this TZ is? Huh? It's the point by which you will see in a point by which where your external os and internal os meet. But sometimes it moves as you age. If it moves outward, the mucosa seems to be quite different on the outside. Parang may lumalabas na pinkish mucosa, quite different from the mucosa on the outside. No? Kasi normally sa labas parang smooth siya, na parang whitish. Pero pag lumabas yung columnar epithelium, it's not smooth, it's corrugated. And it's quite fleshy, no? Moist. Yun ang tinatawag na ectrop yun. If it moves outside, no? And along the border between the squamous and the columnar, this thing happens. Commonly happens. And they say it is associated with certain conditions or events, like if you are promiscuous. What do you mean by that? Sex is your life. Life is sex. That means probably it's your line of work. Kung porn star ka or kung prostitute or something like that, and you have a certain number of patients per night. O patients naman, customers. Some can even accommodate 100 of them. Oh my God! That kind of thing has this kind of problem. Especially if there is associated STIs. What is STI? Infection. That's right. The most common. Interesting question. Okay, I'm not gonna answer that. I thought it would be good for you to know that. They say this is associated with HPV. No? HPV or human papillomavirus. This can be associated with that because it causes some genetic changes in the cell. It transforms the cell. This change can often lead to this one. Slide 17. 70. Yeah. That's squamous cell carcinoma. Invasive. Oh, I forgot the invasive one. But normally I say squamous cell carcinoma, and by that term alone, it is invasive. I don't need to actually say it's invasive. As you can see here, there is this. This is the basic membrane supposedly, but look at those things. There are tongues. Would you remove? Tago lang na to kay Sahay kanya kung same thing. So tongues, islands, fronts, fjords of atypical squamous cells. These squamous cells are often populated by highly anaplastic keratinocytes. There. There. So these are your cells which have large vesicular nuclei, prominent nucleoli. I see a lot of mitotic figures as well. See this? It's a mitotic figure. I think that's somewhere in between prophase and metaphase. The one which lines up in the middle, huh? Metaphase. You see the invasion right there. Okay, and this particular kind has inflammatory cells, like so. You can see it here. Some of these invasions may be found within blood vessels, so that's what you call your vascular invasion, which includes the lymphatic invasion. That's a vascular space right there. It's a Nabothean cyst. Yes, and this is the columnar epithelium. As you can see, this is the mass. Right there. Right there. And this mass is actually very bulky. Huge masses. Right here. The head of a baby coming out. Even larger than that. In some, even the apical portions will manifest erosions and necrosis. So that actually, as you see A of the cervix, you can smell it from a mile away, as they say. It smells rotten flesh. Because of the gangrene or necrosis that has occurred somewhere there. Huge mass. So this is the epithelium. Most of the time, it might be moderately to well differentiated. I think in this case, it's moderately differentiated. Perhaps like you can find some keratin pearls within this invasive islands of squamous cells. So I want you to read about the evolution of the lesion from dysplasia to overt cancer. How does it happen? Why does it happen? Is it clear? Do you understand? Do you have a voice? Please say something. Do you understand? Nasa horror house, gag kasinggit mo. Kaya sulod yung horror house. Bata ang muna ito. Anyway, slide 152. Oh. I suppose this is another example of squamous cell carcinoma. I think it's in the somewhere else. No? I think it's in the esophagus. I think esophagus ba? Do you have your manuals? Oh dear. Bakit wala? Hindi pa nabalik. Okay, anyway, it essentially looks like the same as the one occurring in your cervix. In fact, anywhere else in your body, if you have SCCA, it kind of looks like this. So, populated essentially by this keratinocytes. Sometimes you will see these desmoplastic links between them. And this is what I call your pearl. Keratin pearl, like that. So in a sense, this is a well-differentiated tumor, and you will see the islands invading the connective tissue. That's the mass right there. Squamous cell carcinoma. Slide 187. Ah, very, very iconic. Very easy to identify. ECCA, that's right. If you look at this, you have to look at first at the regular squamous epithelium right there. No? So that's the squamous epithelium. If you look closely, that's the basal portion of the epithelium. And look at the cells populating those basal areas. Huh? They look a little bit darker than the rest. They have this kind of palisading pattern. What do you mean by palisading? Yes, fence-like, arranged in a certain order. And you see that, these are your basal cells. These cells populate your stratum basale or stratum germinativum. They can occur as a tumor. You should see actually a link. I don't see the link. Came from another part usually. Okay. That's the basic feature, no? Palisading at the periphery. And these cells are essentially the same cells that are in the stratum basale. Another feature is presence of this space between the connective tissue and the basal cell right there. This is called your retraction cleft. Retraction cleft is it's an artifact that developed during processing of the tissue. And cells usually give off this kind of artifact if they are basal cell carcinoma. There's a similar tumor that looks almost the same as this, but they don't have the retraction artifact that you can find here. I think it's the trichoepithelioma. I could be wrong, okay? So remember the disclaimer I was telling you about? Huh? You verify the things that I say. So basal cell carcinoma. There are pretty consistent characteristics of this tumor that I believe makes this tumor a good tumor, sort of. It has a good prognosis. I want you to find out what is that. Some basal cell carcinoma. Still an epithelial tumor. Slide 188. Ah. Oh. So it still came from the cells that populate your kana lingkod baluga ang varicose way tambal control lang pero wag yung tambal ng varicose ba sayang ang legs. So actually this one came from the cells that populate your squamous epithelium. As you know, there are many types of cells in there. One type is the one which makes your pigment, the melanin pigment. Okay, the melanocytes. Look at this here. Huh? Right there. So those cells, right there, are your melanocytes. These melanocytes have a sort of strange way of developing. they're quite different from the other cells in this epithelium. As the cells here develop, they go up, 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 up until they reach here when they're dead, producing the keratin layer right there, sealing up everything that's in here. However, your melanin here, melanocyte here, produces melanin. Sometimes the cells in your stratum basale, your basal cells, absorb them, and that's why you have color of your skin. But they themselves can also absorb them or not. They just produce them a lot. And there's an enzyme associated with that melanin pigment. I want you to find out which enzyme is that. And the thing with these types of cells, as they develop, as they become older, they go down your dermis, deep, deep down in the dermis until the subcutaneous tissue, where they are actually quite not different from other cells, because these cells manifest what we call pleomorphism, even as a normal cell. These are notoriously pleomorphic cells, so they can appear like this, like that, rounded to spindle shaped, like that, small, large. Another characteristic is the, yes, right here. Look at that cell. It has an extremely large nucleoli, and the nucleolus I mean, is pink. That's what we call eosinophilic macronucleoli, nucleolus, if it's singular. Okay? That's another characteristic of this tumor. Apart from the pigment that it produces, like so. You see the pleomorphism right there? And sometimes it may invade the lymphatic nodes, and sometimes they conform to the rounded thing that is in there. Might be confused with a lymphoma. Or if they appear in some other organ, they may appear all throughout like this, spindle shape. They may be confused with a rhabdomyosarcoma, or even a fibrosarcoma, or even a leiomyosarcoma. But in fact, they are epithelial, right? Sarcomas are mesenchymal. Now, how do you tell the difference? How? How? By using specialized stain. It stains these melanocytes and not the others. What is that stain? Interesting. Okay. So much with that, melanocarcinoma, or malignant melanoma, as they say. It is what we call Breslow thickness. What is Breslow thickness? Slide 2220. What is this? What is this? Ah, I believe this is an adenocarcinoma. You see these small little gland-like structures. 220. Could be ductal carcinoma of the breast. So you see, this came from the ductal epithelium probably. Huh? You don't have the manual, right? Parang invasive ductal siya na. Invasive ductal carcinoma. So this is an epithelial tumor that came from the ductal cells of the breast. Remember that your breast has actually several types of parts in the TDLU. What is TDLU? Terminal ductal lobular unit. That's the functional unit of your breast tissue. These cells came from probably that, and you will see the increased nuclear cytoplasmic ratio, formation of these small glands, and you will see that these glands are invasive, diffusely so. So parang diffuse invasion. Large cells, there's pleomorphism here, hyperchromatism, and these are highly irregular glands. So, yeah, epithelial, pero adenocarcinoma. That's when you say adeno, gland-like, gland formation. Breast cancer is a very, very invasive cancer. It spreads on early. It's quite common in women of this age, in this century, because slide 216. Ano ito? Pangit siya. Normally daw, my goodness. Do you have a slide of this? Sige lang, yan na. I-ready lang. Slide 103. What is slide 103? Yeah, it's still adeno. But here, I think this is gastric tissue. Gastric ba? You see those gastric glands like so, and then there, that's the cancer right there. So this is your regular gastric gland. You see the arrangement, the nuclear polarity, very, very usual, but I can see some dysplasia here. In fact, Ang cancer na rin ito. So the regular ones are this kind of thing. Those cells are your dysplastic cells, and in fact they're overtly invasive in this area. Yan ang cancer mo. So you can see here there is in the lumen of this gland are necrotic debris and inflammatory cells. So there is brisk mitotic figures as well. Now this is what we call meron siyang glandular fusion. So they fuse, these glands fuse. They have what we call the back-to-back formation, Roman bridging, and all those configurations unique to this kind of adenocarcinoma. This is called the intestinal type. Now, there is another kind of adenocarcinoma associated with the stomach, where the cells appear to be parang small sized, and they have the signet ring cell type appearance. So that's the diffuse kind of adenocarcinoma. This is the intestinal type. And you can clearly see the mass protruding into the lumen of the stomach, right there. Adenocarcinoma. Okay, let's see your slide. Bronchiolo-alveolar carcinoma. So you can see here, this is the affected portion. And let's review a little bit about the regular ones. You see, those are your regular alveolar wall. Huh? It is populated 90% of the time by type 1 pneumocytes. Huh? And sometimes they become crazy, and they behave in a crazy manner. They become like this. Now, recently this has been classified as adenocarcinoma in situ of the lungs. Why? Because they confine themselves onto the surface of the alveoli. They don't invade here. But they have a specific kind of appearance. They look like hobnails. Look at the toenails, your toenails. Look at your toenails. They kind of look like this. That is your toenail, and you have your nail here. Huh? You see? That's hobnailing. Quite the specific appearance of this. And also, they appear like butterflies on a fence. Mga illusions na pa, butterflies on a fence or clothesline, no? So this is supposed to be the clothesline, and the butterflies are here. That's what we call your lipidic pattern. Adenocarcinoma in situ or bronchiolo-alveolar carcinoma. Here, there's a mass right here. Sometimes this mass appear consolidated like pneumonia, in the X-ray. And even in the gross, they may appear like gray stage pneumonia. See that? these cells do not function well. So you will have trouble in the ventilation, perfusion ratio, gas exchange. Patients will experience pulmonary symptoms. All right. 232. I return it before I get it. Tapos na yan. 162 pala. Oh, another adenocarcinoma. So I think this one appears as well in the GIT. Colon ba siya?
Yes, Doc.
So you can see these glands. No? Hyperchromatism, invasion, everything in there. So adenocarcinoma yan. You see the invasion right there? And there is inflammatory infiltrate along with this invasion. So the body tries to protect itself against these tumor cells. Because these tumor cells are essentially foreign bodies to them. They have altered nuclear genetic material which lead to totally different phenotype. Foreign. You see these glands here. These glands here have holes in them. This is what we call your cribriform appearance. Parang sieve-like or salaan gani. So yan. That's cribriform. And the cells that populate them, that line them, are highly atypical. They have hyperchromatism, increased nuclear cell plastic ratio, prominent nucleoli, coarse chromatin pattern, mitotic figures. Most of them have spindle shape, but they have blunt edges. Slide 48.
Oatmeal, what?
This one. This is a lung cancer that sort of originated from one type of cell populating your pulmonary epithelium, respiratory epithelium, as they say, respiratory epithelium. And it's the, I think, the neuroendocrine kind of cell. So these cells are actually classified as the small cell or old cell carcinoma because they are small, they're rounded, they have scanty cytoplasm, and one particular characteristic is presence of massive tumor necrosis. So they look like lymphocytes. There are large areas of necrosis like this one, very faded. And there are also large areas of hemorrhage, like this one on top. Sorry, klaro ba yun? So hemorrhage and necrosis are two of the other basic characteristics of this tumor. They have also what we call nuclear molding. When two nuclei meet, I don't think I will see it here, they sort of have a flattened edge. What is azoparty? Asus. The azoparty effect. They're not that pleomorphic, but they are. Their variation in size is not that much, but they do have. The shape is quite variable depending on where they are, especially when they come in contact with the other nucleus. So nuclear molding ang tawag dyan. So actually your lung cancer has basically two broad categories: the small cell carcinoma and the non-small cell carcinoma. The non-small cell carcinoma can be categorized as squamous cell, the general adenocarcinoma, bronchogenic carcinoma, and the carcinoids and everything else. Small cell carcinoma is a category on its own. I want you to find out why. Why is it categorized as such? Could be due to treatment options. Could be that these cells might respond well to chemotherapy or radiotherapy. Who knows? You should know. Slide 197. What is these? Parang transitional cell. Transitional. Pangit kayo. So transitional cell carcinoma occurs in any portion of your urinary tract because it's the only tract that is lined by transitional cell. And actually transitional cell epithelium is otherwise known as urothelium. So transitional cell carcinoma is otherwise known as urothelial carcinoma. And they happen, or they have this kind of morphology in most cases. They have the papillary pattern. Wala may medium adjustment na ba? So this is the fibrovascular core, very thin, and this is the transitional cells that populate them. In most cases, these cells invade into the muscle beneath, but it is not shown here. It should invade in the smooth muscle of your urinary bladder. What muscle is that? The trousseau muscle. The thickness of the depth is actually proportional to behavior or the prognosis on the tumor. That's what we call papillary kind. There are other types of transitional cell carcinoma. Please read about them. Slide 240. Let's finish this. I think this is thyroid. I can see why. So the cells here are uniform in size. They don't have the pleomorphism. They have prominent nucleoli. They're quite different from the nucleoli that you see in papillary carcinoma. As you know, endocrine gland is an epithelial gland. Okay? It came from the epithelium that differentiated into a specialized cell that secretes specialized products. In this case, they secrete a hormone called thyroid hormone. But these are what we call these cells came from those cells. These cells are your follicular cells. Now, follicular cells here almost do not contain colloid, although there are some very few remnants of it. And they usually are encapsulated. So that's the colloid right there. They are usually encapsulated, but when these cells invade that capsule, actually the morphology does not differ much from the adenoma, ang morphology niya. Pero ang behavior niya lang. One particular difference and the important determining factor of making it cancer is the invasion of the capsule. And you can see it here. It's almost near your skeletal muscle of the neck. No? Yan. Skeletal muscles na yan, no? There. And they're near there. So these are the invasive cells. Like so. They've gone beyond their capsule into that. These cells have capacity to invade the blood vessels as well. So sometimes you will see them growing in bones, like the pelvis. Why is there thyroid tissue in the pelvis? So in most cases, it is follicular cancer because sometimes there may not be apparent in the thyroid. Parang small enlargement lang, cold nodule, but then you will see metastases. Follicular cancer. 239. Ito yung other type of cancer did you see in your thyroid tissue? Papillary carcinoma. This one has papillary structure, and the cells that line up this papillae have the appearance of the orphan Annie eye. You know who Orphan Annie is? That's a comic character in the 1920s. Comic character na siya ba nga, yang mata, puros lang puti, wala yung pupil. Scary, no? Well, that's how they describe this thing. Kind of looks like that. So let's see. Orphan Annie eye, there. Para siyang vesicular, no? Parang clear nuclei. And this is the only determining characteristic of this. Papillae, Orphan Annie eye, nuclei, occurring in your thyroid, highly invasive. More invasive than your follicular, locally. You see that? Invasion. It may or may not be encapsulated. You see this? This is the invasive part. And you can see them near muscles of the neck. You see that? The fibrobascular core right there. And you'll see them in the lymph nodes along the neck area. Level 1 to 4 lymph nodes. Very invasive. When you cut through them, you will see a velvety cut surface. It's because of the papillae. Last one. go to
Seminoma.
seminoma. Ah. This one came from the specialized epithelium of the testis, the germ cells. So this came from the spermatogonia, the cells that form your sperm. So most of these cells have abundant clear cytoplasm. You see that? So this cell has this cytoplasm. They have also large nuclei, prominent nucleoli. They appear in diffuse pattern all throughout the mass. And they have characteristic fine fibrous capsules or fibrous trabeculae that crisscross the tumor, divide them into lobes, like so. And they have also the vasculature there. And it is often associated with lymphocytic infiltrates. So those are your lymphocytes, those dark colored cells, lymphocytic infiltrate yan, no? Like so. So those are your lymphocytes. They're usually coming together with the cells, along particularly your fibrous trabeculae. Now, this has a female counterpart, which actually do not look different. They look almost exactly the same. It's called your dysgerminoma. It's the female counterpart. It occurs in the ovaries. Well, they come from the germ cells. So it just sort of highlights the thing that the male and female are not quite different originally. Can develop similar tumors. But it's important for you to know that this came from the testis, or this came from the ovaries. Okay? Ha? Yan ang tamang quiz ka.
Yes.